Hello, Dr. Eller. Welcome to the podcast.
Greg, thank you for having me. From here on out, you can just call me Mary Ellen. Feels better.
So, Mary Ellen, I don't know if you know this podcast is really the main theme of this podcast is gossip and talking trash.
Perfect.
So I know that you did the David Pewter podcast. And I don't know if you know this, but we're big enemies.
Oh my goodness!
In the podcast space.
Sure. Throw me on the.
He doesn't know who I am. But I want to hear you talk some sauce about Dr. Pewter.
Yeah, big picture stories. Number one, I love Dr. Pewter. I had the honor of being a first-year resident. Well, Dr. Pewter was my chief resident. We both trained at Loma Linda University for our psychiatry residency programs, and I learned so many incredible things from the good Dr. Pewter. He loves all things psychotherapy. One of my favorite stories from my experience in residency is the program I trained in leaned heavily into psychodynamics. It was in Southern California, so some psychoanalytic leanings as well. And Pewter loves therapy. And I went into psychiatry with the mindset that I was going to be really good at everything medication related. Loved the idea of Psychofarm and all the things. And was determined that I was not a therapist. And somewhere in my third year of residency, I had one of the professors sat me down and had a conversation around like, what kind of therapists are you? What are we supposed to, what should we be focusing on? And I flat out said, like, no, I'm not a therapist. I do meds. I love ECT. That's the kind of doctor I am. And they had a very point blank conversation around, unfortunately, you already made the decision to be a therapist when you became a psychiatrist. And the only thing you get to choose from here on out is whether you're going to be a good one or not. That did not come from Pewter, but Pewter after that laid the foundation of modeling how I choose to incorporate therapy into my patient interactions. And then he started a podcast and he let me be on it. So that was a lot of fun.
This is too nice. I want to hear, give us the dirt.
Yeah. All right. So other things you should know about me is I have a very goal-directed mindset. I love some degree of theory if it's applicable and useful. My program, we loved Myers-Briggs conversations. And what I learned about myself is my brain is wired for efficiency. I love doing things quickly. I have had to embrace the process of trying to shift into the mindset of being effective and not necessarily efficient.
Mm-hmm.
And people like the good Dr. Pewter, his brain works very differently. And we had some lovely times as he was an attending physician and I was a lowly resident working underneath him, where he would come to round in the hospital on a Saturday or a Sunday morning, and I would have a list of all the things I needed to do. And Pewter would sit there and want to talk to me about the theory behind just about anything.
Oh my God.
For hours. And my soul would cringe because all I wanted to do was get things done. Once my list is done, I will talk about anything and I will be happy to do it. But I got to get the checklist done first.
That is an experience every single resident has had of being like, yeah, that's great that Kernberg said that, but there's 20 patients to see.
And we've got to get through this list. I've got to write a lot of notes. So it was really lovely. I have been so blessed and honored just to watch. I've had a lot of really wonderful mentors, and Dr. Pewter was one of them, in his ability to find a way to balance meaning and purpose and to build a practice for himself that really incorporates the things that he finds to be most meaningful in his practice and is incredibly valuable to the clients that he treats. And I think that's part of the wonder in psychiatry is that it is not one size fits all. And the world needs some of us who are broad-minded, who want to think about theory, think through how problems develop, and really the psychological aspect of psychiatry. And the world also has a space for the more problem-focused psychiatrists who are checklist-driven, who want to have a problem, who want to see that problem solved, and then are more than happy to pass care on to someone who can carry it. for a longer duration of time because we're built different and clients need access to a variety of different approaches for them to really be able to optimize healing.
That's beautifully put. And we haven't even talked that one of the actual themes of our podcast is integration. That's a beautiful integration, and it takes all kinds. We don't need to put the other side down. And Dr. Peter, I love your podcast. If you probably know who we are. And it's funny you mentioned that, Mary Ellen, because whenever we discuss cases, you nail the formulations in terms of the psychodynamic elements, but you just hear a tone of disdain. Like you actually, to me, are very good at psychodynamic formulation, but it's quick, it's efficient, and it's usually ends with, and I don't like to deal with that.
One of the things I'm very grateful for. My program required all of us residents to have our own individual therapy. And it was mandated for at least 2 years. It was encouraged for all 4. And I, of course, dragged my feet because I'm not a therapist. I don't want to be a therapist. I don't need a therapist. And I proudly finally went to my therapist and let her know, like, this is going to be the easiest hour of her week because I don't have problems. And I am so grateful that my program set that as a requirement, because I learned so much about myself, about how I process information and what my blind spots are. It also helped me become aware of how important being able to understand the value we assign to things, how that changes our language, how we approach problems, how we think through problems, and how we can sit with people. Um, Something that often comes up in supervision is that I prefer anger, which is a funny thing to say. But anger for me is an emotion that generates energy to get things done. Uh, that's not that I am incapable of experiencing other emotions, but in working with my therapist, we learned early on that while I experience other emotions, I very quickly choose to ignore them and choose anger instead, because anger allowed me to get things done. And about a year into therapy, after claiming to have no issues and being, a perfect, highly functional human with no issues whatsoever, my therapist had a beautiful balance of confrontation and asked me one day, if your daughter grows up to be like you, would you be proud?
Oh,
Stopped me in my tracks, and we finally got to work and actually did some really good high quality therapy after that moment, and worked with her for about 3 years.
wow, that's pretty heavy stuff.
Yeah, but it needed to happen.
Yeah.
So now I can jokingly joke about how I choose anger as my primary preferred emotion.
All right.
Uh,
Well, time for probably one of the harshest transitions in our podcast history. Let's talk about ECT.
yeah, one of my favorite things. Not a great segue after being like, "Doctor's angry." Oh, and she's an ECT doctor. That makes
Yeah, I thought it was comical to make that transition. If there's more to say, I apologize.
no, let's just run with it.
So yeah, the goal of this podcast, I know you have something probably pre-planned, but the ideal goal is for people and practitioners and patients who haven't seen ECT to have some sort of idea of what it looks like and who it's for. Um,
Mhm.
and I like that you're very practical. So I think a lot of times when people give lectures, it's like you hear all the theoretical things that isn't whatever. I want people to have an image of when they should be referring to ECT and who it's typically for and what it looks like. And I think a part of that is understanding the history and all that stuff. But that's the goal from the forefront. So I'll pass it over to you and I'll interject randomly.
I will hold you to keeping me on track. Um, but number one, thank you for providing a place to have this conversation. ECT are letters that most people are aware of when they're put in that order, and often come with a lot of emotion or a lot of opinion about what those letters mean. And the unfortunate reality is that ECT has a lot of stigma. It got stigma for good reasons. It's also incredibly effective. It's incredibly safe, and it can be a very important tool that can alleviate suffering in the right population. And while I have had firsthand experience seeing the dramatic improvements that people can have in the process of getting ECT, I'll also be the first to say ECT is not the right decision for everybody. So, to kind of understand that nuance, I think talking about the resistance or why people have fear or anxiety around ECT is probably the best place to start. And to have that conversation, we have to kind of lay the framework of the history of how we came to start doing ECT in the first place. So number one, mental illness is not new. If we look back in the history of the world, for as long as people have been keeping records, there are records of humans who demonstrated the symptoms that we now call things like schizophrenia or bipolar disorder or depression. We've labeled them different things across the years, but those symptom complexes show up across the life course of human history. And we really didn't have any structured way of understanding them or what to do with them. Enter the 1800s. Now we're starting to have more like psychological thinking. We're starting different schools of talk therapy. We're getting some structure around thinking about mental illness, trying to categorize and label things so that we can have shared communication between colleagues. But we really didn't have anything beyond talk therapy. We had no medications. We had no interventions. We couldn't study living brains. So our best way of understanding why symptoms happened were brain injuries. If somebody survived, what was different about them? That's like the curious case of Phineas George. Or studying brains of humans who had died, and trying to make conclusions based out of those ways of studying human behavior. Um, which left us in the dark and taking some random guesses about what was causing these things. And we came up with all sorts of really creative explanations. Um, Probably the most common theme was like witchcraft or possession seemed to be a common thread across most of human history when it comes to mental illness. Um, but as the study of mental illness or brain disease started to have more structure, and we started having more shared language around how to describe these processes that we're seeing, we we came to realize that what we were doing wasn't doing enough for many people. In the early 1930s, right, if you were diagnosed with something like depression and schizophrenia, bipolar disorder, um, the reality for most people is you'd be admitted to an insane asylum and you would never leave.
Mhm.
Uh, Most of the time, you would die within 5 to 10 years, often with catatonia. There are vivid case reports of the courtyards in insane asylums filled with waxy flexibility of catatonic individuals who died of exposure, dehydration. And well-intended people got desperate, desperately trying to help, trying to alleviate suffering when what we had available at that time, which was talk therapy, wasn't enough to talk somebody out of being catatonic. And we tried a lot of things. We got creative. Insulin came along and like woke up some kids. So we're like, "Ooh, let's try that." So we tried some insulin comas. We saw that humans who had epilepsy tended to have less depression. So we tried some creative ways of inducing seizures. One of those was inducing or injecting a medication, but very hard to control as far as what the outcome of exposure to that medicine was going to be. And, we tried cutting people's brains apart, and doing lobotomies, cutting chunks out, seeing if anything we could do could alleviate some suffering. ECT was part of that, and, there are a variety of different stories around ECT came from, but, by and large, the version of ECT that evolved into the form that we have today emerged around the 1930s, 1940s. I think the specific date was around 1938, um, and actually came from Europe, where they were experiencing the same process that we were seeing in the United States, um, where if you get admitted to an asylum, you're likely gonna die there. Um, and, two creative guys, both of them neurologists, were out walking around the streets one day, and they stumbled upon this profoundly psychotic individual. They bring him into the asylum, and instead of using medication to induce seizure, they tried using electricity, and over time, fine-tuned the process of ECT, and that gentleman went from being floridly psychotic to being discharged to the community, which was unheard of in those days. There's not a lot of specific details around those case reports, but from that, we started to develop more technology of how to fine-tune the process. But again, in 1938, you don't have general anesthesia, you don't have meds, You don't have great ways of monitoring EEGs. We were living in the Wild West days of psychiatry, doing the best with what we had. And when many people think of ECT, that's what they still imagine the process is today, right? Of like this incredibly inhumane process of some awake person getting electricity delivered to their head, having this incredibly heroic looking seizure activity, and then like losing their memory afterwards, right? It's kind of how it gets depicted in movies. And if you've never seen ECT, it's easy to imagine that's what it looks like. Um, when I was a med student, part of our third year clerkship experience was getting exposure to ECT. And I I was like somewhere between nervous and excited, right? When you're rotating in medicine and you're like in the emergency department and all of this, like you hear about seizures, but you never actually see them, right? Like someone has a seizure, they end up in the emergency department, you do a post-seizure workup. But it was very rare. I had never witnessed an actual seizure event occur. So part of me was really excited that I was actually going to see something. And I get to the ECT suite and I sit there to watch my first ECT stimulus get delivered. And anticlimactic, so probably a correct word.
Yeah.
Boring was more what I felt in the moment, because at this point, the way that it's delivered, it's delivered using general anesthesia, so the human is fully asleep, their body is fully relaxed with a paralytic, there's no movement observed. The only way to know that a seizure has occurred is by monitoring with an EEG. We do inflate a blood pressure cuff to try and limit the paralyzing, that really profound relaxing medication from getting to at least some part of the body, usually the foot, so that we can preserve access to monitor a motor seizure. But overall, it's incredibly humane, it's incredibly quick, it's incredibly effective, and it's nowhere as graphic as many people imagine it may look like in their mind because of how they've been influenced by uh, movies like One Flew Over a Cuckoo's Nest.
Just a small plug to leave a review if you can. Leaving a review will help other clinicians find our show and will let us keep making it. If you're on Apple Podcasts, open the show page, scroll to ratings and review. If you like us, tap 5 stars. If you're not sure of what to put for the review, just say, "Hi, Dr. Fu." And if you're on Reddit or YouTube, leave a comment. Dr. Fu reads absolutely every single one. Let's get back to the show. Yeah, that movie is the big one that people look back to in terms of like changing people's ideas of what ECT was. If that was the Ken Kesey book, and when it was depicted with Jack Nicholson, it looks like this very graphic tonic-clonic seizure, and then afterwards he comes out just a complete zombie. And it's funny, they were kind of mixing two different things, and now we don't have there's no tonic-clonic seizure, but people aren't a zombie afterwards. With the lobotomy, that's probably a little bit more representative of an extreme version of what that was occurring. But with ECT, it's not like people come out like zombies. I did want to comment on, we think of the treatments as very barbaric, but for some reason my brain thought of like tech support, of like, when tech support comes in and it's like, have you tried turning it off and turning it back on? That's essentially what they were doing with insulin coma, with ECT. They were resetting the computer. Lobotomy is probably like taking out a few of the parts. And then when they moved to psychoanalysis, it was the opposite. Like they just focused on software and totally ignored the hardware. We like to imagine today we're looking at both hardware and software, but we probably haven't quite figured it out either.
I am excited for the day 10 years from now. I look back at how we practice today and I get to say something along the lines of, "Oh, that was cute."
Yeah.
They were doing the best they knew to do. The reality is back, in the 1800s, the early 1900s, we had incredibly good intentions. I have to hold space to believe that that was true. And as we know better, we need to do better. And I think that's kind of where psychiatry as a whole really has an opportunity to accelerate our understanding of disease processes and what kind of treatment algorithms that we develop. from the 2000s, late 1990s, early 2000s, and beyond, functional brain imaging became more widely available. But like truly prior to that, we had no real ability to study living brains in real time. So it truly has only been in the last 20 to 30 years that psychiatry has had an opportunity to start widening our understanding of what's happening in a brain when they're experiencing the symptoms of depression or schizophrenia or what's happening in bipolar disorder, beyond what our best guess is just based on the symptoms that we're able to observe. And tr- up until the last 30 years, right, within psychiatry, that's what we were left with, right, was trying to study or understand our disease processes by the subjective reports of individuals and what happened when we tried something, right? Which is where we came up with really creative ideas like depression must be a serotonin deficit because if you give the human a thing that increases serotonin, they feel less depressed.
Mhm.
So that must be what's wrong. And as we've been able to study living brains, we've been able to understand that yes, serotonin is impacted, but at best, serotonin is impacted as a much more downstream consequence of something else that is happening in that brain much higher up in the system. And for some people, modulating neurotransmitters can bring about significant symptom relief. But many people who try medications alone continue to have symptoms. And so when that's the case, we need to take a step back and think through where can we address these symptoms higher up so we can get closer to the root cause. I truly don't think we have any intervention at this moment that is a root cause intervention. The only place that I could start to argue with myself is in the realm of psychotherapy. Um, in the way that psychotherapy can help address patterns and help modulate our stress response as far as how we perceive our environment, how we process information, and how our body physiologically responds based on how we process. Beyond that, our environment plus our genetics. So, stressors, as far as environmental factors, psychological factors, physical factors, plus our genetic predisposition is the simplest equation for why we end up with chronic disease processes.
Mhm.
We don't have interventions right now to target genetics. We do have a lot of lifestyle strategies that can optimize our epigenetics. So we can have some power over the equation on the genetic side. There are other things from the stressor side, as far as environmental factors, physical factors, and psychological factors, where we can start to modify some stressors, but most people don't go around picking them up and choosing them. Most of the time, our stressors are gifted to us. So we can't always control what stressors we're dealing with. But therapy at least has the ability to modulate how we process those stressors and how our body can respond to those stressors. Um, and when those things lead to disease, we need to have as many treatment options available and understand where those treatments interact with an underlying disease process. Um, as far as I can tell, medications target the most downstream effect from the consequences of that equation that we use in regular practice.
Mhm.
And if you start with targeting the most downstream consequence, it helps me understand why our response and remission rates with medication alone has been as limited as it is. That does not mean that medications are by any means wrong or bad. Medicines have helped an incredible amount of people, and they are a very necessary part of the process of helping somebody heal from a chronic disease. And when medications have not been enough, then we need to find ways to target the system higher up in the process of that disease with the hopes of getting better results.
Yeah. Every I think I love how where you started and where you ended up in this because I I agree. It's almost always felt like I think psychiatry has always felt like we're just a few years away from cracking it. Like there's just a few little things we need to tweak and then like we understand it. And I think the the neurologists thought they had it in the 1900s. The in Vienna, men with Australian accents in the 30s thought they had it with psychoanalysis, and now we think we have it with the next thing. And the it's it's not helpful to think like, oh, if only I was born 10 years from now when they cracked it, because I don't think we're ever going to fully crack it. And I like that you bring up that what we need to do is, with our knowledge right now, provide the best care and do the right algorithms with our knowledge as it currently is. And that's the thing is, I feel like so many patients and providers are like, oh, if only we had the cure. But meanwhile, we're not focusing on what we do know and the algorithms that we should be following. And I like how you bring up, it's like right now, psychiatry, like 95% is practice of medication, next medication, next medication, next medication. And that's not in the algorithm. That's not like, the basic algorithms that we should be learning in med school, in social work school, in NP school isn't medication, 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 medication. And I'm excited because ECT is not even on a lot of practitioners' algorithm, which is terrifying because it's a really good treatment. So yeah, if you wouldn't mind, could you talk a little bit about where you think it fits in, how it fits in? And you mentioned like, medications are great, which we both agree with, but they're limited. When do we move on from medications?
So, my brain is very simple. So I have to come up with very simple ways when I read research and try to synthesize information in a way that makes sense to me. Um, so I'm going to tell you how I understand or think about disease process, and then share how that kind of spills out into my algorithm of how I work with patients. Because for me, I have to at least create in my mind a vision of what it is that I'm trying to do so that I can figure out how I can help. Um, so if we think about that simplistic equation of chronic stressors plus our genetics leads to chronic disease, right? Um, the question becomes why, right? Why do chronic stressors, why do genetics lead to disease? I think the genetics piece, we can kind of table that. I hope that for many people, genetic risk makes sense as to why that might predispose somebody for a disease. It gives us insight as to why one family may have more depressive disorder, while another family may struggle with things like schizophrenia or OCD. All right. And while that can be an incredibly complex conversation, we're just going to leave the genetics kind of off to their self and say no more about them. But when we come to the stressors, all right, so stressors can be environmental. Like I said, they could be physical stressors, they could be emotional stressors. So as I'm sitting with somebody, as I'm listening to their story, those are kind of the big category issues that I'm listening for, is what stressors may have pushed this human system to a state of disease. When we think about environmental stressors, I grew up in Michigan. So the stories around Flint, Michigan and lead exposure and all of the significant impacts that has on brain health is something that sits close to my heart. I grew up about 10 minutes from Flint, so I had a well. But oh, that might be
Yep.
player one. Real simple. I don't know. Uh, but we can't take that part out of the equation, right? So if there are environmental stressors that are triggering or pushing our brain towards disease, we need to be aware of those. We need to address those. From a physical standpoint, we know that things like chronic pain, injuries, those things are stressors for our body, and they elicit a very specific chemical stress response. And psychological stressors elicit also a very prominent stress response, slightly different in the acute phase, transitions to the more chronic stress response. So as I'm sitting with somebody, I'm listening for what are the stressors, what's the family history, what is the likely genetic predisposition that we're dealing with, and then what are the symptoms, what is the disease name that we're going to give this category of symptoms that they're coming to me for. Um, in the event, right, we've been living under chronic stress, the body's response to chronic stress releases chemicals that change how our brain and our body, how our cells interact with each other and how they communicate. In the brain, your brain cells, when they're healthy, should look like big, beautiful broccoli heads. Over time, chronic stress pushes those brain cells to start to look differently. And if you think of the chronic stress model in my simplistic understanding, if you think of your brain as a company, the brain has a set budget, and the brain can't just go around making more money. So when one department needs more money, it has to take it from somewhere else. For many people, that chronic stress response leads to increased staffing or increased demand in the threat detection department. And where it ends up stealing resources from are circuitry or areas in the frontal lobe. If you do SPECT scans or if you do brain imaging, you'll see that different disease processes map to different areas of increased activity and decreased activity. Over time, when you have an area of your brain that is less active, as far as those beautiful broccoli head connections, if you're not using them, they take way too much energy for your brain to maintain them. So what we see over time is a decrease in postsynaptic or receptor density. The cells don't die, but they go from looking like these big, beautiful broccoli heads to sad, wussy asparagus. Part of the medication process is that medications bind to receptors. So if somebody has been dealing with this chronic stress response for a long period of time, and we put medications in a system that already looks like asparagus, if the medication cannot bind, it's going to have a limited ability to target or get that system back on board. Sometimes they work. Sometimes they can bind. The binding or the engagement of that chemical increases availability of the neurotransmitters. More neurotransmitter over time can lead to that process of re-engaging or increasing receptor density. Different medications work on different neurotransmitters. They combine presynaptic versus postsynaptic. They can sit in the cleft. They can work on enzymes. By and large, what we're trying to do is increase neurotransmitter to help increase density so that we can get healthy connection back. So what do we do if we're in asparagus mode and somebody has tried medicine, it didn't work, right? When we look at trials like the STAR*D trial, what we know is that our first medication trial, regardless of what we try, has the highest likelihood of being effective for that individual. When we try our next medicine, and ideally we're going to pick it based on a side effect profile, we're going to use medical judgment to try and determine what medicine could be the best choice for them for their specific symptom complex. But the likelihood of each medication trial treating someone's symptoms to remission goes down exponentially with each trial. And depending on where you look, those numbers could be anywhere, with first medication trial having a chance on average around 30%. Second trial around 20%, and by the time you're on your third medication trial, some studies are reporting a 5% likelihood or less of achieving symptom remission with medication alone. And that includes medication switching, that includes augmentation strategies. And if you step back and you think about these big, beautiful broccoli heads that are now asparagus, it makes sense to me that I can put as many medications into that system as I want. If they can't bind, they're not going to be very effective. So, as we've studied brains and we have learned more about brain circuitry and what circuits are influenced more strongly or are more impacted with certain symptoms, right? And if we can map those circuits within a population, right? So, one example of this is a lot of people with depression, right? We hear issues with sleep regulation, mood regulation, appetite regulation, focus concentration, rumination. And when we do large population studies, we have found that in that circuit, one area that we can reliably target and we can reliably map is to the left dorsolateral prefrontal cortex. Not the only area, but it's one that we like to talk about. And part of that is because it maps fairly well and predictably within a large population set, right? So in that treatment algorithm, if I've tried medications and I haven't gotten a significant symptom response, we haven't achieved symptom remission, my next question is, what can I do? How can I target something more upstream? All right. So if the receptors aren't in a state where they can bind or respond to a medication, maybe I can bypass the receptor set and I can just directly stimulate that circuit using cool principles with like electromagnets and inducing currents. Part of what's happening is as neuroplasticity takes effect, as that circuit gets utilized, that receptor density increases, gets back to a healthier density. That circuit can maintain communication. Medications now have a better chance of binding. Right? So oftentimes what we'll see is in the process of using things like neuromodulation, people who had been partial responders to medications previously or who were being prescribed heroic medication regimens can now have their symptoms maintained on a much more simplistic medication regimen. And that goes back to this equation of stressors plus genetics leading to disease. If we can't do much to address the stressors and we can't do much in the world of genetics, then we need to do something to help protect the brain from going back to the state of disease. And for me, that's where medications are part of this chronic long-term conversation for a lot of individuals. ECT is considered in that world of neuromodulation. ECT comes along and says, I don't care. ECT says, I am not going to pick one circuit. I am going to affect all the circuits. And that is the process of inducing a seizure. All right. So a seizure happens when all of the brain cells in your brain start talking at the same time. What we've learned in the process of doing ECT is that by repeatedly stimulating that brain activity, what we can see is widespread normalization of those areas of hyperdensity and hypodensity that come with that disease process. Does that make any sense? I
Yes.
just
So
realized I've been talking for a long time. I use my hands a lot. It made sense to me.
that was super helpful.
It made sense to you.
I'm paying attention to time. We probably have about 15 minutes left. And the pivot I want to make is I want to have you be the clinician and
Okay.
answer questions as though not role play. I'm saying like essentially for practitioners who haven't seen ECT, who haven't done ECT, what would like let's say I'm a patient and you're the medication prescriber and you're trying to talk to me about ECT to see if it's a viable option for me. I
Okay.
want to hear essentially like what your spiel, and I think what you kind of just mentioned is a big part of that spiel. But
Mhm.
I want it to have it be very practical for the patient, like for a clinician to be able to answer like how they would answer questions in terms of like what's this going to look like, how many times am I going to go in, is this how likely is this to work, what are the side effects. So I want to hear essentially like what would your spiel be to a patient who doesn't know about ECT and
Mhm.
giving them an idea so that they have an image in their head of what it looks like.
Yeah. Um, so oftentimes we broach this conversation because we've tried medicine. Usually this conversation, we should start having it the moment we start medication trial number 2, right? So someone comes in, they have a symptom complex, we prescribe a medication, we refer them to psychotherapy, they follow up 2 months down the road, partial response, we've optimized the dose. The moment we're having to start talking about a second medication trial or augmentation strategies is the right time to start laying the foundation of how these medicines are supposed to be helping, what we expect, what we're monitoring for to make sure that they're doing what they need to do. And if you're not the 30% that gets remission with a medication alone, this is not the end of the road. There are a lot of other and different ways that we can target the symptoms and get you relief. So starting the conversation early is really important. All of my patients, unfortunately for them, have to suffer through Eller's TED Talk to help the sick brain understands why we get to a disease process as the foundation for the recommendations that I'm going to make. Um, with that, I think a lot of people feel a sense of hopelessness. Oftentimes, when somebody is getting referred to me for ECT, the average number of medication trials is greater than 12. By the time they show up, they're feeling hopeless. They're feeling like this is the last stop on their journey, that if this doesn't work, there's nothing else for them. And that paired with the frustration of every time I go to a doctor, they just give me another pill or they tell me to take more of it. And for a brain, especially for talking about depression, oftentimes they're already feeling the sense of being a failure, being maybe not worthy of being helped. And that process of treatment and this constant cycling of trying new things, more things, often is easy for them to reinforce that thought process of I'm a burden, I'm a failure, I'm too much, that goes hand in hand with the type of ruminative thoughts that we see in depression.
Mhm.
So I try to lay the foundation for my clients of why symptoms occur, or my understanding of why symptoms occur, and what the pathway for treating those can be. ECT is also not the end of the road. There's all sorts of options beyond ECT if we go there, if it is partially effective or if it doesn't have durability for people. But perfect scenario is that the world of neuromodulation opens up for clients. That conversation, it may get mentioned when we're starting trial number 2, because if medication trial number 2 is ineffective, medication trial number 3, our likelihood of that working is less, and that's when we should be making referrals for neuromodulation.
Mhm.
Um, when we talk about ECT, I think highlighting that electroconvulsive therapy, the moment those letters or that word comes out of your mouth, I have seen a variety of reactions.
Yeah.
Um, Oftentimes, the individual with depression is desperate enough for relief that they are willing to sign up for just about anything. Um, I have had to have some creative conversations around informed consent for individuals who had depression and were actively suicidal, and they hear that under general anesthesia, there's a chance of dying, and that's their indication that they want to sign up. That's a bit of a red flag, but also highlights the desperation that many people are in when ECT becomes part of the conversation. My experience is that most of the time, at least in the world of depression, the human with depression is desperate for help. And often it's their support, the support around them, husband, wife, parents, that has the most resistance to the idea of doing ECT, because they've heard that it's going to wipe out their memory, it's going to turn my loved one into somebody completely different. Um, and so talking around the side effects, the risk benefits of ECT is critical to having that conversation. Um, Sometimes people bring up references to like One Flew Over a Cuckoo's Nest and how this is just incredibly inhumane and like the blight of psychiatry's existence. Um, in those conversations, I will often kind of lay the foundation of the way ECT is done now looks nothing like the way that it was done in the 1900s. Um, I often lead with humor, whether it's good or not, and I will often say something along the lines of how frustrated I am that my profession is still being held accountable for what we did in the 1900s, but you're not going to your internal medicine doctor and yelling at him when he recommends an EKG because he used to bloodlet people and throw leeches on them, right? Just not fair. Uh, but oftentimes that's as far as that initial conversation goes, is just laying the foundation of yeah, there are good reasons why you're anxious about this. There's been a lot of misinformation. That misinformation didn't come out of nowhere. This treatment looked real different in 1940, and it looks very different in 2026. Because of that, the side effects that people used to have in the 1950s and the 1960s is actually quite a different side effect profile than we have the way that we have fine-tuned the procedure now in 2026. The biggest resistance for most people is the fear around memory and memory concerns. So, having explicit conversations around what those risks are is really important as far as an informed consent is concerned. It's also really important for me that family is aware of what to look for because I may make adjustments in the way that I deliver the stimulus if they're seeing more short term memory issues or confusion than I would consider to be normal in the process of doing ECT.
Mhm. I'm paying attention to time. We have 10 minutes. I'm going to give you a rapid fire set of questions. Okay.
I'm going to try to be precise.
Okay. Okay. So you mentioned in terms of where in the algorithm you recommend ECT. What patients do you see have the best response, or do you really push for ECT?
So, things that respond incredibly well to ECT and poorly to other things, depression with psychosis. Interestingly, the older you are, the better your response rates, and that's pretty unique with ECT. Bipolar mania, incredibly effective. It can also target bipolar depression, but the moment you have unipolar depression, or mania and psychosis, ECT is incredibly effective. The other disease process that ECT has the biggest claim to fame in treating is catatonia. Catatonia can be reversed. I've seen it reversed with as few as one ECT treatment. I've also seen it take longer, so it's one of the more unpredictable treatment courses, but it is the most effective way of treating catatonia. And in an ambulatory outpatient setting, the moment you see depression with psychotic features, especially in an older individual, that's a human that would be a really, really good ECT candidate.
Mhm. Patients that it's not good for, patients that are contraindications.
So there's no absolute contraindication for ECT. However, anytime you have a seizure, you get a parasympathetic surge during the seizure itself. So your blood pressure goes low and your heart rate goes low. Immediately post seizure, you get a sympathetic surge. So you get a significant increase in blood pressure and heart rate. For most people, their body accommodates within 30 seconds to 2 minutes. But we do need to make sure that your heart is healthy enough to tolerate those blood pressure and heart rate changes. If you have an aneurysm, you may not be a good ECT candidate. I'm going to ask a lot of questions to make sure that those blood pressure changes are safe enough with your aneurysm history. If you've had a heart attack in the last 6 months, if you have had a stroke in the last 6 months, we need to do some significant medical clearance. And usually, if you've had a heart attack or a stroke, ECT is off the table for at least 6 months to give your brain and your body time to heal. Other things that are on the list of reasons to keep ECT in mind. So, pregnancy, especially if a pregnant female is experiencing mania or psychosis or depression that is putting her life and the life of her fetus at risk, ECT is effective and it is rapidly acting. Um, the medications that we use to deliver ECT, so like the general anesthetic medications, they are generally considered to be safe in pregnancy. So in bipolar disorder, where the mainstay treatments like lithium and antipsychotics do have the potential of having some effect on the fetus's development, ECT is considered safer, especially if we are dealing with emerging risk of suicidality or potential psychosis leading to homicidality. To do our best to keep both mom and fetus safe.
Awesome. What are the side effects?
So, generally speaking, side effects, anytime you're under general anesthesia, there are side effects that come along with general anesthesia. So, headache, nausea, muscle stiffness or soreness from the paralytic agent, nausea as you're waking up. And you should be confused after you're coming out of general anesthesia, but that confusion usually lasts 15 minutes or less. From having a seizure specifically, seizure activity leads to increased blood flow to your brain afterwards to basically clean up the byproducts of what happened during that seizure. Anytime your brain has increased blood flow, that is the experience of a headache. So headaches are very common. The other specific side effect related to ECT is in the process of inducing a seizure, seizures impact memory consolidation. Generally speaking, rule of thumb, for your brain to remember a thing, it takes 2 weeks. So when I induce a seizure, it is possible that you can have some short-term memory impact for 2 weeks prior to your first ECT treatment. And I would expect short-term memory issues to linger for up to 2 weeks after your last ECT treatment. If you're in the midst of an index series and you're getting exposed to general anesthesia and having a seizure 3 times a week for 4 weeks straight, um, I'm going to expect some significant short-term memory issues. Now, what's really fascinating is depression itself is has a profound impact on memory and memory consolidation. Sleep as well has a significant impact in memory and memory consolidation. So while the risk of memory and short-term memory issues is something we keep a close eye on with ECT, when we have studied it across the population, over 30%, so between 30 and 40% of individuals who are in the midst of their index series have a better mini mental status exam score despite seizures and anesthesia exposure by their 6th treatment. Now, that's not everybody. 15% of people had worse mentation.
Yeah.
Right? So it's not a zero risk, but in the process of informed consent, it's critical for people to know that doing nothing is a treatment option. They can choose not to treat their disease, but doing nothing and allowing a disease process to run rampant or run its course can have profound impacts, especially on memory. Not to mention all the other downstream consequences of undertreated mental illness like depression, schizophrenia, and bipolar disorder.
All right, last big question. What does it what does it actually look like for the patient? How many times are they going in? Are they driving themselves? Is it an all-day thing? Is it 10 times a week? Is it 2 times a week? Is it forever?
Good questions. So the answer is a little variable depending on the disease that we are treating. So in a disease like catatonia, the answer is you're going to do ECT treatments 3 times a week until you're not catatonic. That might be 1 treatment. That might be 12. We're monitoring symptoms, and we know that we're done with that Monday, Wednesday, Friday treatment course the moment your catatonia isn't recurring. Depression is a much more standard treatment course. When I'm consenting somebody for ECT for major depressive disorder, I expect them to do 12 treatments. We try to do 3 treatments a week. Because this treatment is generally most effective in older individuals, some people have a harder time rebounding after anesthesia. So if they're having just profound tiredness, fatigue on the days between ECT, we can move it to twice a week if we need to. But um, the sooner we get through that index course, the sooner they're going to start feeling better. So if we can maintain 3 a week for an average of 12 treatments for depression, then we're going to get through it in 4 weeks. And in depression, there's reported anywhere between a 60 to 90% remission rate. All right. So the sooner we can get there, the sooner people can start feeling better. But if we have to pull it down to twice a week because of side effects, then we can do that. Bipolar disorder is a little bit different as well. Typically, we treat whatever side of the disease phase that we're in, we treat to symptom remission +3. So if somebody comes to me with bipolar depression and we start our index course, they're going to do treatments Monday, Wednesday, Friday. And if at the end of treatment number 6, they tell me my depression's gone, I'm feeling wonderful, I'm sleeping, I'm not hypomanic or manic, I'm just not depressed, then we're going to do 3 more treatments Monday, Wednesday, Friday, and then we're going to convert usually over to maintenance. Similarly, in mania, we're going to treat it the same way. There is some concern, and it's hard to know if what we're dealing with is just the natural course of the bipolar illness, because oftentimes people who are coming out of a depressogenic episode, that's their high-risk period of time for swinging into hypomania or mania. And even more profoundly is that most people after a manic episode, the majority will experience a depressogenic episode as they come out of that manic episode. So not 100% clear if ECT itself is a potential trigger for mania or the depressogenic side, or if what we're doing is just accelerating the healing process and then the natural disease course is to swing from one to the other. So we're very cautious not to overtreat because we don't want to risk sending someone towards the opposite disease phase in the event ECT has the risk of doing that. But we're going to monitor closely. Once we get done with ECT, the goal is to stay in remission. So typically what we'll do, I'll have somebody come back for maintenance treatment 1 month after they finish their index course. If no symptoms have recurred during that 1 month period of time, then we'll decide if we want to stay at 1 month. Usually what I'd recommend is coming in at a 2-month mark. If no symptoms recur during that 2 months, we might push it to 3 months. Some people get done with index and they choose not to come back or do maintenance care. The one issue, once we're in the realm of needing interventional services, is that many of our interventions struggle when it comes to long-term durability. And I think a lot of that is that reflection of those chronic stressors plus genetic predisposition leading towards disease. And whatever we can do to optimize that equation helps to promote durability of effect. You did ask as well, do people drive themselves to anesthesia or to ECT? And the answer is absolutely not. Anytime you're under general anesthesia, you may not operate a motor vehicle for 24 hours post-anesthesia. So ECT is not the right choice for people who are trying to actively work while getting treatment. You can't drive yourself back and forth from work. I would expect you to be tired and have some short-term memory issues. So if somebody is actively employed and working, we often have to do short-term disability or FMLA to get them time off work to protect their ability to do ECT. But that's one of the barriers as far as why ECT may not be the right choice for some people. The other piece is you have to have resources in place for ECT to be delivered safely. So you need someone to drive you back and forth to treatments. After anesthesia, you should have somebody, like a responsible adult, available to you if you have any issues. Not everybody has the luxury of having a friend who can drive them back and forth or who can stay with them 12 times in a month. So those become very practical barriers as far as thinking through who ECT can be an appropriate intervention for.
This was wonderful and super helpful. I think we should schedule another one soon. Thank you so much for taking the time.
If we need 30 more minutes to wrap up in a better way, you just let me know and find some time to throw it on it.
We're practical though. We'll wrap up fast. All right. Thank you so much.
Bye, Greg.
All right, bye.